Welcome to the ACO Show. I'm Josh Israel, joined as always by my co-host Sean Cavanaugh, and we are here with a podcast about some of the people who are trying to make the American healthcare system better. Hi, Sean.
Hey, Josh.
Our guest today was Michael Chernew. He is somebody who you have known and worked with over the years, so I'm going to hand the introduction over to you.
Yeah, thanks, Josh. Dr. Chernew is a professor of health policy at Harvard Medical School. He's written a lot about accountable care, and so he would be of interest to this podcast and our listeners if that's all that he was. But the real reason I wanted to have him on now is he, for a couple of years now, has been chairman of something called the Medicare Payment Advisory Commission, MedPAC. That commission was created by Congress to advise them on the highly technical issues around Medicare payment. So I thought it would be good to have doctors, clinicians, other healthcare workers around the country who listen to this show see a little bit of insight into an organization they might not be familiar with, but that has a lot of influence on the creation of the laws that they live under.
He clearly has done a lot of thinking about some very important issues that affect us all. He covered a lot of ground. Let's take a listen.
We are joined today by Dr. Michael Chernew. Michael has two important roles in our healthcare system. One, he's chairman of the Medicare Payment Advisory Commission. And two, he is a professor of health policy at Harvard Medical School. Welcome, Michael.
Sean, it is so good to be here. And Josh, it's nice to meet you.
So for our listeners, let's start by explaining one of your roles. What exactly is MedPAC and what are you doing over there?
So MedPAC is the Medicare Payment Advisory Commission, and it's an independent federal agency that advises Congress on Medicare payment policies and a bunch of other related Medicare policies. So there's 17 commissioners, including myself. There's a small but unbelievably dedicated and productive staff. We make update recommendations for Medicare fee schedules. We make recommendations related to Medicare Advantage, Part D. So I encourage all your listeners to check it out.
A funny thing happened recently. Wall Street Journal took exception to some of the work of MedPAC, and then in the end of their editorial, they said, why do we need a MedPAC? So why do we need a MedPAC?
Yeah, well, I'm going to be speaking today in my role as a Harvard professor, not my role as MedPAC chair, which is probably important as I answer this question. But the Medicare program is unbelievably complex. And Congress, in creating MedPAC, was trying to get a body of experts and staff to provide technical support related to questions like how fast should hospital fees rise, how fast should physician fees rise. And of course, now half of the program is in Medicare Advantage. So we get asked questions about Medicare Advantage. And I think that general advice ends up being important given so many of the Medicare questions are actually technical questions. And MedPAC is a technical body. We're a nonpartisan body. We try and provide evidence to Congress to support them in the policy decisions that they make.
You know, one of the reasons that the government wants advice on Medicare is people are often talking about and often worrying about Medicare solvency. I still vividly remember Al Gore talking about the magical Medicare lockbox. What are they talking about? And is that a real thing?
So a few things. So broadly, I think they're largely talking about the hospital insurance trust fund, the Part A trust fund, because that most of that, not all of it, most of it's financed by our payroll taxes. And so people will say things occasionally like Medicare is going to go bankrupt. And what they basically mean is that that trust fund is going to run out of money when that happens. If it happened, I don't think it will, but if it did happen, payment rates would have to be reduced in order to be able to be funded with the money that is sort of coming in. And so I think that's what's broadly being discussed. MedPAC's charge is actually not to fundamentally protect the trust fund, although we do try and make sure our recommendations are cognizant of being good steward of societal resources. MedPAC's goal is to try and find and make recommendations to, for example, in payment rates, to support the efficient provision of care so that Medicare beneficiaries can have access to high quality care. That's essentially what drives it. You can solve the fiscal problems in the Medicare program through revenue increases or cost reductions. We don't really address the revenue side. We deal with the cost side, and our guiding principles on the cost side, there's a bunch, but largely we're trying to come up with appropriate payment rates to support access to high quality care. That's more of a guiding principle than fundamentally trying to hit some budget target, which is not how we make our decisions.
So Michael, you talked about the types of recommendations MedPAC makes. I want to dive a little deeper into an area that MedPAC has spent time on, but you also in your role as a professor spent time on, which is the Medicare Shared Savings Program. You did some of the early analyses of how the program was performing. Can you tell what you found in those early years?
Yeah, so the answer is pretty straightforward. The program saved money and it kept quality the same, maybe improved quality. Quality is harder to measure, so I say that with less confidence. But certainly, I think the evidence was very clear that the way the Medicare Shared Savings Program was structured, for that matter, other ACO programs, the Pioneer Program, for example, did reduce overall Medicare program spending.
I have found the debates over whether the MSSP program saves money quite puzzling. We see at Aledade when we start working with practices, by year 2, 3, they fairly consistently have lower rates of hospitalization, lower rates of ED visits, lower blood pressure, and good studies will come out showing saving billions of dollars, the program overall. And then someone else who seems quite smart, quite well-intended, will publish the opposite. You mentioned the lack of control group. Are there other reasons that this is still a disputed topic?
I think the programs have changed. My takeaway is some version of the somewhat frustrating sentence. If you design these programs well, we've shown that they can actually do quite well. And we actually believe that ACOs in general can transform care for the better. But if there's problems in how the programs are designed, particularly how benchmarks are set, where there's incentives for selection or other things, then in fact the programs might not save money and in fact could cost money. And so a lot of this is about the program design and the execution of what's going on. And I think we do have to, I 100% agree with the critics that would say we need to think about the details of the design, because it's not some sort of automatic thing that these things save money. The amount of money depends on the way you've set them up. The amount of money you save and the quality effects and all that stuff depends on the way you set them up.
So some of what you said sounds very similar to what the new leadership at CMS has said, which is we think this program is working, we think it could do better. What are the design elements that you're referring to that you think could generate better savings in the long run?
I think so. First of all, this is a question I should ask you all, since you guys do this all the time. So I feel sheepish answering this. If I ever had a podcast, I'd have you on and ask you the exact same question. But I'm going to answer since I'm supposed to. So the main thing that I would focus on is aspects of the benchmark setting process. There's a lot of things there, regionalization, what's called the ratchet. So one of the problems with the design that I spend a lot of time worrying about is if everyone were in ACOs, and all the ACOs succeeded, over time, the benchmarks would get rebased or ratcheted down, making it harder and harder and harder to win. And I think finding ways to solve that problem, not just for any given organization, but sort of collectively, is quite hard to do. I think harmonizing the MSSP with all the other programs matters. Again, you guys could tell me since you do it, one of the things that I have worried a lot about is just broad confusion in the system. There's so many different models launching so many different things. It's so hard for organizations. They're not deciding, do I stay in fee-for-service? Do I join an ACO? They're deciding which ACO, which track of MSSP. There's a bunch of new codes in the fee-for-service system that reward people for chronic management and a bunch of stuff. And so someone has to figure out, are we better off in the traditional fee-for-service system and billing these codes? Should we go into an ACO program? And how does that play out? I actually think there's roles for organizations like Aledade in supporting those primary care groups. But it is hard to practice medicine in general. And it is really hard to practice medicine if you have a lot of people trying to tell you how to practice medicine and a lot of different incentives underlying that to sort out. And we have built a very, very administratively cumbersome system to try and do a relatively basic thing, which is to mitigate some of the inherent distortions that I see occurring in the fee-for-service system. And I think ACOs are a mechanism, not the only, but a mechanism to do that. And I think improving the benchmark setting, particularly the ratcheting, some of the add-on payments is really what you need to do in order to make the program run more smoothly and just stabilize and harmonize it.
There was a bump, as I'm sure you're aware, in 2026 of growth in ACOs. But in general, the program has not grown all that much, despite CMS saying that they have a goal of many more people in accountable care. Do you have thoughts on what CMS could do?
Yes, my answer is going to be somewhat similar to my last one. But first, let me say, and this is important, I'm a big supporter, I think I'm a big supporter of alternative payment model in general, ACOs in particular, for the reasons I said. I'm happy to talk about that why more in great length. But I do want to point out my support for that isn't some inherent desire to have ACOs per se. And so I don't view enrollment in ACOs as the ultimate goal. And so I don't think an answer will just pay them even more and then everybody will join. That's not what I think the ultimate goal is. the ultimate goal is to use ACOs as a tool to accomplish sort of more efficient delivery of care. And I think the type of thing is that we need to think through is how the ACO program fits in with other programs. I actually think changing the MA program might be the most important thing to support the ACO program, because if you siphon a bunch of people into MA plans, it's harder to succeed in the ACO program. I wouldn't use that as a motivation for reforming the MA program, but I think there's other reasons why the MA program needs to be reformed. I think supporting primary care infrastructure writ large will help the ACO program because it's fundamentally built around primary care. But other than that, I think you just have to design a program that's stable enough with a benchmark setting regime that's reasonable enough that encourages people to go in to understand that these programs give the providers the ability to share in the savings that they can generate, as the Shared Savings Program title would suggest. And I think that's a really important role in payment.
So we've been talking about the Shared Savings Program, which, as you said, resides for good or ill in the traditional Medicare program. But more than half the beneficiaries are now in Medicare Advantage. One of the things I was hoping you could shed some light on is there's this ongoing debate. I think it's a bit one-sided, but it still continues. Does Medicare Advantage save the government money? MedPAC a year or two ago came out and said sort of boldly, it's never saved in 30 years, never saved any money. The industry itself, though, has studies on their side claiming that it does save money. I welcome you to take a side in that debate, but more importantly for our listeners, can you explain what's at the heart of this disagreement?
My personal view is that the government is spending more on Medicare Advantage and they're getting more for Medicare Advantage. But just because you're getting more for Medicare Advantage doesn't mean you're spending less. So Medicare Advantage, it's often said Medicare Advantage has an out-of-pocket maximum. That's why it costs more. Sure, but that doesn't mean it doesn't cost more. There are legitimate debates about the methodology that MedPAC uses to estimate what drives the differential payment. And there's a wide range of academics unaffiliated with MedPAC that have gone into this debate about what we're paying for Medicare Advantage. And I would argue that the vast majority, actually, I can't think of any contrary ones, of high quality academic studies would basically support the conclusion that Medicare Advantage is costing more than would be spent on those beneficiaries by the government if they were in the fee-for-service system. And that's not to take any away from Medicare Advantage. We get something for that amount of money. We could debate how much or its value, but we get stuff for that money. You could argue, I actually think the biggest unknown is the extent to which the Medicare program, or for that matter, ACOs, transform the entire system. So there's savings that are going on that are sort of collective. That's a reasonable point to make. But from the standard accounting of we pay X amount of money for my dad to be in Medicare, and if he joins Medicare Advantage, we're going to pay Y amount of money. Y is going to be bigger than X. My dad would get more, but Y is going to be bigger than X.
Michael, I don't watch a lot of network television. Just trying to get that flex in here. But the short amount that I watched, multiple TV commercials, tell your congressman, tell the president, don't cut Medicare Advantage benefits. What is MedPAC's stance on those? I mean, I hear you, what you're saying, that we might be paying more, we might be getting more. Does MedPAC have a take on what to do about all these supplemental benefits?
MedPAC does not have a take on what to do with the supplemental benefits per se. I think MedPAC's view is, in my view, is we need to know more about the value of those benefits. And to some extent, it depends on Congress deciding how they want to finance those benefits. And I think that's the core policy trade-off. The Medicare program, the basic Medicare design, has a lot of gaps in it, hence the term Medigap coverage. People pay out of pocket for physician visits, for hospital visits, and most Americans find one way or another to supplement that. One of those mechanisms is through Medicare Advantage. And so that's valuable. But when you finance that as extra benefits, you end up paying more. MedPAC's focus largely has been on aspects of efficiency in the system. And as I think I mentioned at the beginning when I described MedPAC, it does some really technical things that, again, I'm happy to talk about, like estimate coding effects or selection effects, or the role of certain strategies in documenting disease, which influences payment. And MedPAC's recommendations fundamentally focus on tightening up some of those programs and where they think congressional intent was. Congress, in its wisdom, can do whatever it wants with the information, but MedPAC recommendations tend to involve adjusting for some of these differences in, for example, the way the risk adjustment system is working.
Michael, thanks for sharing all your wisdom with us. Before we wrap up, just, this sort of big picture question. As you mentioned, MedPAC deals with a lot of very specific and technical issues, but you're an observer of the American healthcare system. As you look forward, what are the major challenges in the healthcare system writ large that we're facing?
So I'm going to give you two, Sean. I'll try and be brief. The first one's, I think, obvious. It's affordability. Healthcare spending's been rising 7-ish%. In the commercial sector, we're seeing rise spending, pushing 10% in some places. And Americans just can't afford a bunch of their healthcare. And that is, I think, a core part of the problem. There's a question as to why. I think there's a myriad of explanations. I think at the end of the day, the fundamental explanation is that the cost to deliver care is rising. That includes the prices for expensive, sometimes very valuable, but nevertheless expensive medications. It includes use of services that maybe we shouldn't be using. It involves aspects of pricing related to consolidation and a bunch of other things going in the healthcare system. But because our system is so fragmented, getting our hands around this is important. Oftentimes, folks blame the insurers. I don't want to absolve the insurers from their role in this. I think in some ways their role is to help the American healthcare system become more efficient. But I certainly think they aren't ground zero for what our core affordability problems are. I think our core affordability problems relate to the underlying costs of delivering care and what's happening in the delivery system. And I certainly think that more efficient practice of primary care and medicine in general is going to be an important part of that solution. So number one big issue is how do we manage affordability in this very complex system? And that gets to my second big challenge is the system is just too complex for people deciding what to enroll in. The Medicare Advantage program is very complex. The administrative burden associated with known as revenue cycle, which is people deliver services and they bill for the claims and someone denies the claims and it goes back and forth. And just for people to understand who's in their network, what benefits are covered, which plans can they choose, how do they get that information, how do they trust that information? Josh asked about the ads on TV in a whole bunch of ways. A lot of them, involve spending a lot of money trying to support people and navigating what is an unbelievably frustrating healthcare system. And I think part of the issue there is I value highly a lot of the autonomy of individuals in their care and the doctors and how they seek care and the care that's delivered. But I think, again, as the small area variations literature showed, if you just give everybody all that autonomy, things go all over the map and you spend a lot of money in a fee-for-service system. So some aspect of simplification of the system, which may involve some standardization, which has its own trade-offs. But I think that type of work is needed to meet the core goal of making the system fiscally sustainable so we can enjoy the healthcare that we should. I'm not sure my appendix burst. I can't say there's anything about the healthcare I enjoyed, but I enjoyed it more than what the alternative would have been. So we need to have access to high quality care. Health is amongst the most important things that Americans have. And we actually have a very, talented group of professionals delivering care. And we need to have them work in an environment that just doesn't drive them crazy. And we need people to be engaged in the healthcare system in a way that doesn't drive them crazy or bankrupt them. And that requires, I think, some simplification, some addressing some of the underlying delivery issues. And so I appreciate all the work that Alade's doing. I know others are as well, in trying to make this a little more seamless. And I think the regulatory system needs to continue to evolve in ways that sort of supports that underlying mission of high quality care at an affordable price.
Well, Michael Chernew, who is currently the chair of the Medicare Payment Advisory Commission, MedPAC, and also at the Department of Healthcare Policy at Harvard Medical School. Thank you so much for joining us.
Josh, thanks tons. Sean, always good to talk.